before I continue. And so I'm very excited to introduce our presenter today. We have Dr. Laurie Twells with us. She's a professor in the Faculty of Medicine. She's also the Assistant Dean of Clinical Research, and she served as the Scientific Director of NL Support from 2018 to 2019. So thanks so much, Dr. Twells, for joining us today. And I'll pass it along to you to get started with the presentation.
Right, excellent. Thank you, Julia. I'll just do my own little check-in here, and maybe you can check the chat. Let me know if everybody can hear me. And also potentially see me, although I know my video is on, but I can't see myself. So I'm assuming that everything's okay with noise and video.
Good, Laurie, it's Holly, all good.
Okay, perfect. Right, let me just move over here. Okay, so we'll get started. So yes, well, as Julia said, I'm a professor here in the Faculty of Medicine. I've been on faculty here since 2007, and I'm currently the Assistant Dean of Clinical Research as well. So what I decided to talk about today is in some ways what could be considered a simple topic, but in other ways is probably the most complex and critical piece of doing research. And it's come to me over the last number of years from just teaching in the clinical epidemiology program for over almost 15 years now, in terms of dealing with students, and not just students, but colleagues and other faculty, in terms of coming up with either research questions or trying to define research questions. So the title of my talk today, or webinar, is Conducting Clinical Research, Identifying the Research Question, the Critical First Step. Okay, so in terms of presentation outline, what I'm going to spend the next sort of 30 or 40 or 45 minutes talking about are the research process and where research ideas originate from, why the research question is critically important, some of the relatively simple and probably well-known criteria for some of the people on the line to how we might guide and develop our research questions, but they're certainly the most common ones that are used, my own experience with research ideas and questions, and some examples of research questions. So just to start off with, because research is a broad topic, and I'm kind of specifically focusing in on what I'll call clinical research here today, which is the systematic investigation towards increasing the sum of knowledge. So that's research in itself. And clinical research is really the science of human disease investigation with a focus on diagnosis, prognosis, and treatment. And to a certain extent, that extends a little bit further than that when we talk about things that are happening in the healthcare system as well, in terms of health services delivery, as well as health system policy. But again, we're really, I guess my focus of my talk is more about the applied research side of things, because that's what I am, a clinical epidemiologist. And most of the research I've done since I've started doing research has been clinical research, and that I've always worked with clinical faculty, clinicians, healthcare professionals. So that's the lens I'll bring to this today. So where does research, or where do research ideas come from? And I'd just like to stop for 1 minute, and for people on the call, to just think about the research you're either currently involved in or the research you've completed. Where did your research question actually come from? You can either put it in the chat or just have a think about it, but I just want you to dwell on that for 30 seconds or so. I'm just going to give you a little bit of time to think about it. You know, where did the research idea or research question come from? Okay, so we've got an unmet need, clinical practice, literature review, untreated diseases. Throw it in the chat if you can think about it, from a question not answered, some driven by funding opportunity, exactly. Some news in the media around a hot topic, yep. Okay, well, those are some ideas, and absolutely right. So I've got the top hat there because at the end of the day, research doesn't come out of a hat. By definition, it's a systematic investigation. So ideas don't really come out of thin air, so to speak. Research ideas come from a variety of different areas, and then this list is in no way comprehensive. But individually, it can come from your own passion or interest. It can come because of your own lived experience or family members' lived experiences. It can come from funding opportunities like CIHR and NSERC. The funding opportunities, in some ways, people often think, well, I'm not going to just do research because there's a funding opportunity. But the reality is the people that sit on the boards of CIHR and NSERC are also people like us who are actually always looking for and defining the funding opportunities that should be provided. And they can relate to all sorts of things going on out in the real world in terms of clinical or any other type of research that, in fact, you may not actually be up with. One particular example I would say at the moment is the funding opportunities that came out starting maybe 2 to 3 years ago around the cannabis industry, around cannabis regulation. And there's been multi-million-dollar funding opportunities that have come from a new industry in Canada, but a new regulated industry around cannabis. So if you were somebody who was actually looking to start up a program of research, potentially interested in policy research as well as health, you might have gone after some of these big funding opportunities, as did a number of colleagues that I know here at the university. They may not have been interested in cannabis in the first perspective or from their own perspective, but they saw it as an opportunity. Often your research can come from your supervisors, your colleagues in terms of potentially publication of case reports or case series, especially clinical faculty, your own clinical experience, which was just mentioned in the chat, or observations you've seen. New health policies, for example, the tax on sugar sweetened beverages that was just announced by our own provincial government a few months ago. Opportunities that lend themselves. These are things that might happen in the healthcare system. And in particular, I'll talk about an opportunity that I sort of was able to capitalize on a number of years ago. New knowledge or big data that presents itself and gives you new findings, for example, to explore new discoveries in terms of genetics, and industry, for example, in terms of public-private partnerships. So research ideas come from a number of different places. And the 10 most common reasons why journals reject articles are here. And I've highlighted the top 3 in particular around the research question. So the topic itself is unimportant or irrelevant. So that's your research idea. And your peer review process is telling you this isn't important anymore, and actually it's quite irrelevant. It's probably been done. We've either answered the question, we have sufficient information to know what we're talking about here in terms of evidence. It's insufficient or incomplete problem statement. So again, we're talking about the research question. We haven't quite made the rationale for it. We haven't given the background properly, and we haven't made the case in terms of our research question. We've done an inadequate review of the literature, meaning that, again, we're really not quite totally up to date with what's actually known and not known and what the gaps are in terms of our research question. So again, the rationale for your research question. So these are some of the top reasons why, when you come up with a research question, you've conducted the research, you've analyzed the data, you've now submitted your review or your original research for publication, why your work may in fact not get published. And as you can see, some of the top reasons are all related to the research question or the research problem. A lot of these other things are related more to the methods piece in terms of sample size, data reporting, insufficient data, overinterpretation of results or exaggeration of results, etc. So some of the criteria that we often point students towards, and ourselves to a certain extent, are relatively similar, but they are the criteria that are very well known and used when looking at a research question. And if you haven't ever done this with your own research question, it's certainly something that is worth doing in terms of guiding your research question or your research idea. And this criteria is simply called, from an acronym perspective, the FINER criteria. And it stands for, is your research question feasible? Is it interesting? Is it novel? Is it ethically relevant? And is it relevant? And I'm just going to go through some of these in a little bit more detail. And one thing I will say is that some of this criteria will be quite different in how you interpret it based on where you are in your career. What might be feasible for me now, 15 years as a faculty member and as a full professor, certainly wouldn't have been feasible to me 15 years ago when I started off my faculty position as an assistant professor. So some of it is contextual in terms of where you sit in your career, your contacts, your colleagues, the infrastructure you've now got in place. So again, it's not going to be the same for everybody. When we talk about feasible, we are talking about the environment of where the research will take place. We're talking about absolutely the sample size, how many people you might need to recruit to actually conduct a study. If you want to conduct a study here on a rare form of childhood cancer, and potentially not even a rare form, you may find that there aren't enough, the population would not be large enough here to do a provincial study on rare childhood cancer. You would absolutely have to do a multi-province, if not multi-country study. Again, would that be feasible for somebody starting off in a position or a student? Probably not. What about the time frame? How long do you intend on being here in terms of your research? Is it a study that might take several years in terms of data collection, or could you do it retrospectively and you actually use data that's already collected? What's the effect size you're looking at? Again, you're looking at sample size considerations here. Resources, again, access to expertise and consultation. Is it a study that in fact needs a pilot study? If you're actually looking to submit an application for a large funding for a study, you often need preliminary data, if not a pilot study already conducted, to show in fact that you can do what you're setting out to do and that you've actually got some preliminary results to actually provide some evidence for your hypothesis. Is it interesting? Again, sounds like you yourself might think this is interesting from a personal or passionate perspective. You might be interested in this particular piece of research from a professional perspective in terms of promotion, reputation building on your own expertise. Do your colleagues or peers think it's an interesting topic? There's nothing better than brainstorming with colleagues and peers around ideas that you do have. And I would certainly suggest people do that. When it comes to funding, if a funding call has gone out, it often needs a priority from a national perspective in terms of research. But again, is this something interesting from your perspective? When it comes to actually conducting research, it's very difficult to do research if you yourself are not interested in the topic. For most people potentially here on the call, or any of us that are interested and conduct research, research is a difficult activity. It takes time, it takes expertise, it takes perseverance. It takes a lot of what you might call failures in the sense of actually looking for funding and not receiving funding. So it's really got to be something that you are quite interested in. And again, in terms of resources, you're always looking for the broader set of resources in terms of actually being able to conduct your research. Novel is a critical question, but it doesn't always mean that you're going to be doing groundbreaking research. In fact, most of us will never do groundbreaking research. And to a certain extent, groundbreaking research by definition isn't often groundbreaking because it's systematic in the sense that it has been building on knowledge before its time. It doesn't mean that you might not do a study that actually is done on a different population, in a different geography, in a different way, using a different study method. You might be confirming previous findings that were, for example, established in a case control study, and now you've either done a cohort study or a clinical trial, which provides a higher level of evidence for those findings. You might be doing a study to actually refute previous findings, where there's some inconsistency in reporting, or you might be doing a study just to extend the knowledge of previous findings. This particular number of studies was done previously. We'd like to expand on that knowledge by, in fact, either using more tools or instruments, expanding the patient population, it may be studying patients for a longer time period. So again, there's all sorts of ways to make the argument that your research is novel. When it comes to ethical, most of us will be aware of the fact that any research done on humans has to go through a research ethics board. So I won't get into this in too much detail other than to say that when you actually write a research proposal, that research proposal will also go to an ethics board, which will then be reviewed by an ethics committee. I sat on the ethics committee here for 5 years, where we will actually review all the applications to make sure that from an ethical perspective, so whether it's recruiting patients, whether patients are consented and knowledgeable about actually being part of studies, whether the patients will be safe within a study. Sometimes you're weighing up benefits and risks, and there may be risks associated with being as part of a study, but will the benefits outweigh the risks? These are discussions you might have at an ethics board. In particular, a big area of ethical concern is often confidentiality and privacy. So how do we ensure that actually patient information or any study participant information is kept confidential and private? Often these days when you're doing research, it's all about removing identifiers. And a simple identifier that needs to often be removed or may not even be given to you when you're doing research is postal code. For example, so apart from things like MCP and date of birth and name, postal code is very much an identifier that can actually help you place somebody not only in a community, but often on a street or in a house. And that often has to be removed. And again, when it comes to actually keeping patient data safe, where is it stored, who has access to it? So those are the types of things that you would need to consider when you actually develop a research proposal, but in fact, they will also be reviewed by your provincial or institutional ethics board. Finally, is your research relevant? Getting back to those top 10 reasons why research manuscripts are often not accepted. So relevance, again, can hit a number of different areas, and these won't be all of them. But, what is the research actually showing you? Are we improving patient outcomes? Are we improving patient care or approaches to patient care? Is there an improvement around patient safety? Would your research potentially guide recommendations or inform standard protocols or potentially be involved in practice guidelines? Is it generalizable? What's the external validity? One of the other key components of any research by definition is that it isn't just particular to that particular subject, that particular area or that particular time. Research by definition should be generalizable to a larger population. And that's where your external validity comes in. And again, what types of questions are you answering? Are you solving problems? Are you elucidating relationships in terms of, for example, a causal relationship? So again, does your research question pass the most important question? Whoops, sorry, let me skipped ahead here. And this is an interesting question because this is a question that was certainly put forth to me through my doctoral degree numerous times. And in some ways it feels, it's a bit of an aggressive question when you're actually doing research as a student. But it's something that I've taken with me even as I've gone forward as faculty, and I've certainly put it forward to my own students and potentially colleagues sometimes, which is, this is an area you want to do research in. This is an area you find fascinating. You think there's a need for research, and the kind of a response from somebody outside that realm is, so what? You want to do research here? This is your question, so what? What does it mean? What are you trying to answer? Why does it matter? And it's something that you can ask yourself sometimes, to just dig yourself down further and further and further into terms of determining, what is the point here of your research? Okay, you can go through that finer criteria as well, but you need to be able to explain to somebody, and especially a funding body where funding is so competitive these days, is what is the point of your research? What are you building on? What are the gaps? What do we know? What do you intend to find out? And how will that actually do whatever it is it's meant to do, whether it's improving patient care, elucidating relationships, etc. One thing to be aware of here when you are doing your research is the difference between statistical significance versus clinical significance. Again, finding significant differences from a statistical perspective is absolutely what's needed to show that you just haven't found a solution or found an answer to a problem by chance. But you've also got to be aware of that when it comes to clinical research, is there clinical significance here? Increasing, for example, a quality of life validated scale by 2 or 3 points might very well be statistically significant, but if it takes 20 points to increase that scale to change clinical management, then it's not clinically significant. So again, just things to think about when you're actually also kind of trying to define your question, as well as determine, what is the relevance here in terms of what I'm doing. Apart from sort of guiding the research question, we also need to determine and be quite good at, I would say, developing very focused research questions. What I find and what I have found over the years of not just teaching students, but working with colleagues, and it's just come from experience and skills and knowledge that I myself have developed over the last 15 years, is getting very focused about the research question. Sometimes the research question almost seems to be too focused in one way or another, but actually you've got to answer a very focused research question. That's a necessity. We often talk about the focused research question in terms of your PICO format. And again, simple acronyms that we use, very much used by librarians, always used in terms of searches, in terms of sort of PubMed, Medline, any of your general searches that you'll do on a platform when you're looking for articles, for example. And very simply, it really is talking about the population. So what specific population are you interested in? The intervention or exposure. What is your intervention? What is your exposure? And these need to be defined. If it's a study where there's a control group, you want to know what the alternative is. How are you defining control? What is your outcome? And most often here, we're talking about your primary outcome. Why? Because your primary outcome dictates what your sample size will be in a study where you're actually going to be recruiting study participants. You may have secondary outcomes. You may in fact be reporting on a number of different outcomes, but it's really your primary outcome that will dictate, for the most part, your sample size. Again, what will you measure? How will you look for improvement, for example? How will you define the effect on the primary outcome? What is it you're setting out to accomplish in terms of your primary outcome? And then, not always, but often you might include a time component. So what is the appropriate follow-up time to assess the outcome that you're actually trying to study? So those are some of just the general criteria that you might use to help you inform or guide your research question. So what I want to sort of bring to the group now is just how this works in real life. I mean, how does a research idea come about? How does a research opportunity appear? How do questions come from research ideas? And so I'm going to talk through a number of slides here to just demonstrate to you an opportunity that I was able to avail of and why. Again, not something that came out of a hat, not something that came out of thin air. There would always be a context even around an opportunity. So when I was finishing up my doctoral work in around 2005, 2006, my doctoral work had actually focused on obesity in Newfoundland and Labrador and its impact on the healthcare system. This in itself had come from an opportunity of data sets that had only just recently become available at the federal level, where we were actually looking at obesity across the provinces and territories and comparing provinces. And we all of a sudden had national data sets where we could do that. So I actually spent almost 5 years exploring that data in this province and came away with a very good knowledge of and understanding of obesity and its impact on the healthcare system. It led to a number of papers, the top one here just being the Obesity Predicts Primary Healthcare Visits, a cohort study where I looked at sort of a number of years, several thousand people and their impact on the healthcare system. I then moved sort of into looking at the prevention piece, which I've continued to do as well, actually looking at infant nutrition, the early years of nutrition in a child's life, and conducted a study related to breastfeeding and childhood obesity in Newfoundland and Labrador with Dr. Leanne Newhook. But I guess it gave me the context of understanding obesity. And certainly in our population, 1 in 3 adults is obese. In fact, 1 in 4 children are overweight or obese before they actually go to preschool. And in terms of the doctoral work I did, what I really determined was that people living with severe obesity, and those would be people defined as having a body mass index greater than 35, were really the people that were impacting the healthcare system the most. Those were the group of people that actually had several chronic conditions, anywhere between probably 2 and 14, most having 3, and typically your high-risk cardiovascular conditions, hypertension, dyslipidemia, and type 2 diabetes. And this equated to about 30,000 people in this province. So that was the context and kind of what I came away from when I finished my doctoral degree. At that point in time, we were already seeing this right across Canada. So again, when you look at obesity as a marker of obesity and health risk, you often define it in terms of class 1, 2, and 3. And it's the class 3 obesity, so that's your BMIs greater than 35, that actually we're seeing the largest increase right across the country. There were regional variations, but right across the country, we were seeing an increase. in that sort of severe obesity group of people, which again was the group that we really should have been most concerned about when it came to the healthcare system. So at this point in time, I'd actually managed to find myself in a faculty position in 2007, 2008, and had carried on doing some of that obesity work, as well as other bits of work as well, working with colleagues and clinicians. But in 2010, in December, an opportunity arose. I'd actually been in contact with Dr. Dave Pace, one of the bariatric surgeons here. And him and I had been talking for over about a year, talking about the potential of a treatment that might be approved here at Eastern Health related to severe obesity. And at the time, I was actually very much focused on the prevention piece, the management piece, the impact on the healthcare system. And I thought, okay, interesting, but I'm not quite sure if I'm really interested in the treatment perspective. But as time went on, I became more interested. And this opportunity arose where in the 2006 clinical practice guidelines, one of the recommendations for the treatment of severe obesity was bariatric surgery. Now, bariatric surgery at the time was primarily what would have been either gastric bypass or banding. And for the most part, it's only really given to eligible patients. So those are patients with a BMI greater than 35, plus a comorbidity, usually diabetes or hypertension, or a BMI greater than 40. So these are people who are living with severe obesity, very much impaired quality of life, reduced life expectancy, and a number of other comorbid conditions as well. So at this point in time, Eastern Health had agreed to fund laparoscopic sleeve gastrectomy, which was a new type of bariatric surgery, about 100 to 150 procedures a year. And they established a multidisciplinary team, including surgeons, nurse practitioners, and a dietitian. So at this point in time, I thought, okay, this is going to be interesting because this is an investigational procedure. We don't know a lot about the procedure itself. We certainly don't know a lot about the outcomes that are available. But actually, when we looked at the data, and I'm just pointing out her 2010, and you can see her laparoscopic sleeve gastrectomy in 2010 was really only just starting out. So yes, we'd had gastric bypass that was actually happening here in Canada over a number of years, but now we had a new or an investigational procedure that really was fairly unknown in 2010. So obviously a huge opportunity for research. So given the context that I'd already done my doctoral work in, the research kind of direction I was going in, this seemed like an amazing opportunity that I obviously was not going to give up. And so very quickly, I developed a research team and what I would call a program of research. And it didn't happen overnight. It obviously took some time. But part of this relates to the research question in terms of how we define our questions and how questions develop into programs of research. So obviously, because it was a surgical procedure, it meant reaching out to the surgeons themselves. It was a new procedure in Eastern Health, so I knew we were going to have buy-in from Eastern Health. So that meant reaching out to people in Eastern Health, decision makers, VPs of surgical services, et cetera. Connecting with people who I thought might want to work with me. There was no way that I was going to be able to potentially either answer all the questions that needed to be answered or in fact develop a program of research on my own. And I reached out to a number of colleagues that are here in this picture as well, whether they were other researchers, statisticians, the surgeons, endocrinologists, pharmacists, very quickly started to take on students as things developed over time. And obviously one of the first things that you would need to do is identify the gaps in the research literature. So yes, this was an investigational procedure, but what was already known about gastric bypass or banding? What was known about bariatric surgery in general? What were the unknowns when it came to sleeve gastrectomy? So we, as a group, we started to sort of go through the literature and start to decide on some of the key relevant research questions. And we were very fortunate in that, given it was a new procedure, we were also defining the data that we would collect before the procedure even started to take place. And based on the literature, what this meant is that although there was clinical information that was going to be collected, we were now adding research data to that clinical information as well. And that we had to jump through some hoops to do that, actually. But we made the case for a number of things to be collected that wouldn't have been collected clinically that would be relevant for patients. So for example, things like quality of life or patient reported outcome measures, micronutrient deficiencies. So we wanted to know a little bit more about vitamin intake before and after surgery. And there were a number of other things. So we developed and planned a prospective study. We obviously wrote research grants and sought funding and established a program of research. One of the other things that was a huge opportunity at the time was that actually in 2010, that fall, before laparoscopic sleeve gastrectomy had actually been recommended as an investigational procedure, a report had come out from CIHR and Obesity Canada called Developing a Research Agenda to Support Bariatric Care in Canada as a consequence of what we could see in terms of that trend data, in terms of obesity rates increasing. And in fact, this was a very comprehensive report that started to define the types of research questions that we needed to answer and what was unknown in the world of bariatric surgery. So again, a great opportunity to jump on the bandwagon when it came to research. When it came to some of the questions around sleeve gastrectomy, these were just some of the questions that came to light. And in certainly no ways comprehensive. And in fact, we've answered many of these and others. But again, when you look at it from a clinical perspective or a patient perspective, thinking about it from a patient coming in to talk to a bariatric surgeon, you might be asking questions like, what is sleeve gastrectomy? Are there other options in terms of weight loss? If you've been referred by a general practitioner for your severe obesity and related to weight, these are the different types of things you might be asking a clinician. Okay, we're doing sleeve gastrectomy here. How does it compare to other surgical procedures? Why aren't we doing gastric bypass or banding here, for example? Sleeve gastrectomy has been the choice for the bariatric surgeons here. And it's been often related more to surgeon choice around complications and long-term follow-up, which has been shown to be quite comparable to gastric bypass. Are there non-surgical weight loss options? How much weight might I lose? How will this improve my quality of life? What will happen with my type 2 diabetes, hypertension, or sleep apnea that I have? What are the risks of surgery? This is an elective procedure. Why would I want to put myself in any risk? Are there any long-term complications? What does the procedure look like? Will I be micronutrient deficient? Do I have to take vitamins for the rest of my life? These were all unanswered questions as it related to sleeve gastrectomy, and other health system questions related to the impact in terms of costs on the system. How will it impact healthcare use, for example, medication use? Is it a cost-saving procedure? Gastric bypass had already been shown to be cost-effective, but actually was a cost saving. And these were some of the questions that policymakers wanted to know as well. So in terms of our overarching research question, in a sort of general PICO format, which also met what we then considered the finer criteria, and we did go through that criteria at the time, was ineligible patients, and for us it was between 19 and 17 years, who undergo bariatric surgery, and we actually had a sample size of about 200. Does LSG impact the following outcomes post-surgery compared to pre-surgery? Things like weight losses was our primary outcome, comorbid conditions, of which there were several, health-related quality of life, which we then had to define and then choose validated health-related quality of life instruments to assess. Nutrient deficiencies. One of the things about removing a part of your stomach is the unknowns around absorption of nutrient deficiencies, among other things, as well as the healthcare use and costs. So again, we had policymakers who were part of that research team that actually were asking us, what will be the impact on health services used? What will be the impact on costs? So as I said, we designed a population-based prospective cohort study where we actually assessed patients before surgery and every 6 months up to 2 years, and then mid to long-term post-surgery. In some ways, we also made we're able to align with the clinical recommendations, which were to follow patients for 2 years. So patients were meant to come back every 6 months for a checkup with the bariatric surgery team. And it was during that time that we actually collected our data. If we had to meet with patients, we did. And so we actually had no other sort of time commitment from patients other than the follow-up that was already recommended by the bariatric care team. Now, the mid to long-term post-surgery was obviously a research study that came afterwards, and we've in fact just completed that recently. So based on this one opportunity, a research idea that sort of came about, being able to use some expertise and skills and knowledge in the area, reach out to mentors, reach out to colleagues, make contacts, review the literature. We developed a program of research and have accomplished a number of studies over the last decade. Some of these were related to pre-surgical studies. Some of them were related to the cohort itself in terms of follow-up, that 2-year follow-up and the long-term follow-up, as well as other studies that came to light from residents and students around complications of surgery, et cetera. And then post-surgical studies as well. Not every study we submitted to be funded was funded, but the majority were. And we've really become known across Canada as a group that in fact is publishing probably almost the most research around bariatric care, in particular around sleeve gastrectomy in any province of Canada. Most provinces in the country are actually providing bariatric surgery, banding, gastric bypass, and sleeve gastrectomy. And so actually they have reduced data on sleeve gastrectomy, even though it's a growing procedure. So again, we've tended to be a group where we had that opportunity. And in fact, as much as there's research on all bariatric surgery, the fact that we have more on laparoscopic sleeve has meant that our studies are relatively novel. And again, you know, it is the sort of funding flows from your research questions meeting those criteria of what I would call the finer criteria. And we've been quite successful. So that was the opportunity that arose from my perspective and where some of those research questions came from. What I thought I'd also do is really just touch a little bit on some examples of research objectives and research questions. Again, because, you know, just looking at many people who've signed on here today and knowing many people are students as well, this is an area that I've also seen students kind of struggle with a little bit as well. So, you know, defining that research question so that it's researchable, that it's feasible, so that it's doable. When you look at research questions in a paper, they're sometimes difficult to find. Sometimes a research question isn't actually laid out in the paper as a research question, even though for the most part it should be, but you will find often that it's not. Usually in the abstract, you will find the study aim. Sometimes you'll find the study question, it just depends. But most often you will find a study aim or a study objective. So in this example, this is a study I did a number of years ago with a number of pharmacy colleagues, as well as a family practice physician, looking at the difference in pharmacist-managed anticoagulation compared to physician-managed anticoagulation in a family medicine clinic. So in this particular study, our abstract provides that aim. And further in the study, in the introduction, you would find our PICO question, which is in patients on warfarin attending a family medicine clinic, does pharmacist anticoagulation management compared to usual care, which was the physician-managed anticoagulation, result in differences in the percent of time patients' INR was in the therapeutic range over a 17-month period. So again, very specific. It tells you what you're going to be doing. It tells you what your primary outcome is. It tells you what the comparator was. Those things still need to be defined very much so for yourself. But if you have a clear research question and you continue to go back to the clear research question, you know what you're doing. And you don't, you know, it's easy sometimes to even go off on a tangent yourself when you're doing research, but you've got to go back to the research question to determine what was the question we were trying to answer. And this was a retrospective cohort study. Another study that I completed over the last number of years, again, looked at obesity prevalence in relation to children. The objective in the abstract reads, the objective of this study is to compare the prevalence estimates of overweight and obesity in preschool children using 3 growth references. And from a PICO or format around exposure, because obviously there was no intervention here, in preschool children in Newfoundland, so they were children under the age of 5, are there differences in the prevalence of overweight and obesity? Again, there would be a definition in the paper using 3 growth references. So 3 growth references are used to define overweight and obesity, and depending on which growth reference you use, you end up reporting quite a different, differently higher or lower prevalence of overweight and obesity in children. And again, a descriptive study, a cross-sectional analysis. Another study we did, which was connected to our bariatric care program of research done by a resident, was looking at the usefulness and costs of routine contrast studies after laparoscopic sleeve gastrectomy for detecting staple line leaks, which are one of the complications of laparoscopic sleeve gastrectomy in terms of removal of part of the stomach, and then the stomach gets stapled shut. And if you end up with a staple line leak, obviously that can lead to very serious complications. So it's one of the ones that you certainly are looking out for and don't want to happen in patients. But the gastrographin swallow test really was the research around it in terms of its usefulness was inconsistent. So we had a resident actually conduct this study. The objective in the actual study itself was to examine the usefulness of the gastrographin swallow test as an early detection test for staple line leaks on post-surgery, day 1 after laparoscopic sleeve gastrectomy. From a PICO perspective, in eligible patients who underwent LSG surgery between 2010 and 2014, was the gastrographin swallow test sensitive and specific in the early detection of staple line leaks? So again, that's where you're looking at sensitivity and specificity in terms of whether it's actually picking up the leaks when they occur or not. And as it turns out, it was not a very sensitive and specific test. And in fact, the bariatric surgeon stopped using it as a way to detect staple line leaks. This was a retrospective cohort study where we went back to actually analyze data that had already been collected. This is an example of a study where the aim or objective is not specifically stated in the background or the methods. It's a randomized controlled trial looking at liraglutide for the management of weight loss. And these are, we've done some research on looking at the impact of drugs in relation to weight loss as a non-surgical weight intervention. But it's interesting, again, that, say, for example, in the New England Journal of Medicine, there's no obvious study aim or objective stated. You have to look into the paper, and even then it's not actually stated very well to actually determine either what the aim or objective is or what the PICO question is. And here, really, the PICO question is in patients without type 2 diabetes who are overweight or obese, did 3 milligrams of liraglutide compared to placebo result in significant weight loss? And again, significant weight loss then has a particular definition attached to it. This is a double-blind randomized control trial. So again, research questions themselves are not always placed very obviously in the abstract or the paper. And one of the things I would certainly suggest for students or anybody reading papers is to ask themselves when they do read a paper, what is the research question? Because the research question lends itself to the study design. It lends itself to how the results are reported, have the results actually reported and answer the research question, and they most definitely impact the discussion and the conclusion. And as I said before, in terms of reasons why papers are not accepted for publication, it's usually in relation to that research question, and it's linked to results, discussion, and conclusion, what might be considered to be the very basics of actually doing research. Just very quickly, again, where do you find the research question? It should be in the abstract, not always. This helps editors forward it on to reviewers who are generally experts or at least have some knowledge in the area. In the abstract, it's often stated as an objective or aim, but not a question, and most certainly not a full PICO question. And usually you will find a more detailed question in the introduction section in the last sentence, right before the method starts. So again, if you're looking for that research question, go to the introduction, go to the last 1 or 2 sentences right before the methods, and you should see the research question. Again, not necessarily a PICO format, but it should be a relatively well-defined research question. Just another, this is the time quickly here. From a clinical area perspective, another thing to note, and I didn't want to get into this in too much detail because there wasn't time, but when you're looking at the type of clinical area you're studying, the clinical area itself helps you define the type of research question that you might be asking. And then that in itself helps you define the research study. So for example, if you're looking at a diagnosis or a diagnostic question, for example, the type of question might be what disease is responsible for abnormal findings, you're most likely going to be looking at a prospective blind comparison to a gold standard study or a cross-sectional study, right? Not a clinical trial here. A therapy question is best answered using a randomized control trial, not always able to be answered using a clinical trial because of maybe lack of equipoise, meaning, not totally inconsistent study results. So you wouldn't want to actually experiment on people. You might therefore have to use a cohort study. Your best study for a therapy question is always going to be a clinical trial with a comparator. When you're looking at prognosis, so for example, what are the expected outcomes of a disease? What's the longevity? If you're diagnosed with a disease, what will happen next? Primarily looking at longitudinal studies. They don't have to be prospective in terms of waiting 20 years to see what the outcomes are. For example, from a slow-growing cancer, you could go back and do a retrospective analysis on data that was already collected. So a retrospective cohort. Prevention, the types of questions you might be looking at in terms of preventing or delaying disease. That can really be a number of different study designs. It hits all categories really. When you're looking at a harm question, so whether it's an adverse drug event or an outcome that would be harmful to patients, obviously you're never going to put patients in harm's way. For the most part, you will primarily be doing something like a case control study, where you're actually starting with the harm factor or the outcome of interest, which is the adverse drug event, for example, and looking back in time. You may end up doing a nested case control study and a cohort study. So data may be collected prospectively. You're not setting out to put anybody in harm's way, but you might then in fact find that things happen, in which case you can look back at exposures. And we've actually dealt with some of this in our bariatric study, where we've had some adverse effects happen while we followed data prospectively. We didn't set out to look at the harm outcomes, but they've happened. And now we've since developed a case control study. Again, with a randomized clinical trial, you would never randomize people to a harmful intervention or not, but you might in fact find harmful things happen, in which case it will lend itself to studying them. So just the last couple of slides here to sum up really. A poorly devised research question will affect everything that you do from there forward. It affects the choice of study design. It decreases the chance of determining anything of clinical relevance or significance. Again, if you're underpowered in terms of sample size, and it will impact the potential for publication. So you've gotten your question, you've done the work, you've analyzed your data, you're now ready for publication. A question that's not really researched well up front, you'll reduce your chances for publication. So again, without time spent up front developing the research question, the quality of your study and subsequent results may be compromised. And I say this because often, and I refer to students, but it can be faculty and any new investigators when you're starting out, you're very keen to start off doing research, getting to the research, starting the data collection. And often that time spent up front in terms of either ideas, questions, the research, around the literature review. What's known, what are the gaps? This takes the most time, but it's actually the most important piece of any study you will do. Just some final thoughts here. When you look at, when you're writing a manuscript, for example, and you're trying to answer these questions. So did your study answer your research question? The results provide the evidence for the answer, right? That's where the answer to your question should be. When you have a research question, go to your results. Did it answer the question? Be clear, be precise. There's no subjective interpretation here. There's no subjective wording in the results section. It's basically data. It's either tables, it's text, it's figures. The discussion builds the bridge to the introduction where the question was first formulated. You have your question at the end of the introduction. The discussion should pick up from there. Did you find an answer? What was your answer? Was it confirmed or contradicted by others? Put it in the context of other research that's been done. And the conclusion, again, answers the research question in 1 or 2 sentences. They should all flow through like a very easy to follow storyline. And for your research to be relevant, your research should be relevant, provide new understanding, and expand knowledge, and inform new research questions. And the point about research being systematic is that your research will lead to new ideas, new questions, and new research studies. So that's it. Thank you, everybody, for listening. And I don't know how much time we have for a few questions, but looks like we have a couple of minutes.
So as I mentioned, feel free to put your questions if you have any in the chat, or you can unmute yourself and ask a question that way. Or maybe it's not a question, it could be a comment or.
Or an experience. If anybody, has a comment about just research questions in general, or how they in fact came to some of the research questions that they've answered through their research, or what they found.
Or everybody's just taking it all in, thinking about it.
Hi, it's Peter Daly. Thanks for that, Laurie. I think research questions for our residents in internal medicine comes from their experience in the clinic and in the ward, and they identify a problem that they would like to see treated better or prevented or tried to manage. And so it comes out of clinical work that they come to a question, and then we try to help them define that in the PICO format. So same sort of process. Thank you.
Yeah, I mean, one of the things, Peter, just talking with residents over the few years, I guess, is what's your view on, the other pieces of that? So I guess, there's the clinical observations they see as a resident. Do you find they often go to fruition? Are they things where there's already answers, for example, clinically, but they don't know them?
Of course, that's part of it, and a good supervisor will define the extent of the previous knowledge so that if a resident comes with a question and we say, we already know the answer to that, then there's no sense doing that as a research question. So, and of course, you're right, residents don't have all the background information, so they don't necessarily know what's in the literature, but we might turn them back and say, go read more and come back with a bit of a stronger understanding of the current question before you ask the question yourself.
Yeah. So I think for as trainees go, I mean, that's one of the key things I would say from a trainee perspective is, whether it's a supervisor, a mentor, another colleague, those conversations can be critical in terms of just reducing time spent that's either not, is wasted or providing direction, which is, this has been done, we know the answer. Yes, it's interesting, but, kind of move on, or we need to know more. And I think at the trainee level, that's the bit that's sometimes challenging versus if you are embedded in an area where you actually now know quite a bit. It's easy to really kind of just work out what's almost relevant, what's not, quite quickly. Yeah.
Yeah, for sure. And, in a place with a small priority on research in general, we don't have a lot of advanced research type people available. So the number of faculty for mentorship of residents is relatively small.
Yeah. Yeah.
Hi, Laurie, it's Holly. Could I jump in real quick?
Yep.
Sorry, I'm eating my lunch at home. I'll just say this quickly because I know we're at the end of this, but I do think this is a worthy topic. So I really like the review. I think it's good for all of us to think about research questions and way we should be doing them well. You made a really brief comment about that separation almost between clinical care data and research data when you're doing your bariatric work. I come across that a lot as well, trying to think about, so I study a lot of genetics issues that have to do with, informed consent, for example. And I think, well, wait, now, are we talking about at the point of clinical care, or is this a research study? So that separation, I think, sometimes between clinical care and research is not helpful, in my opinion. I think as a system, I'd love to see us take that discussion further. I'm just curious because that sounds like you've probably come across it a little bit as well in your bariatric sort of project.
Yeah, so I guess, I think the pie in the sky is that eventually, and I know Peter could speak to this, the learning healthcare system, data that's collected clinically would be research data. Yeah. And I think that is, I say pie in the sky here because it's happening in other countries, in particular the UK, where every clinical encounter is documented and it's there for research. And we're definitely headed that way. I guess the point being is, we could be waiting a long time. So, we have to work out what are the opportunities that we can jump on. For us, from the clinical perspective, from a bariatric program, the recommendations for patients to come back every 6 months for 2 years was an easy one. Okay, let's jump on to 6 months. They're coming back anyway.
Yeah.
We had clinical data being collected, but then we also wanted PROMS data. We wanted patient-reported outcome measures. So we had to say, okay, look, if patients come in, can we have a research nurse down there to actually administer 3 quality of life healthcare surveys? We also want healthcare use data. Okay, we need to get consent for data linkages. We're just at the point now where we're analyzing 10-year data use. So, some of that is there, that data use piece is there. It's research, it's clinical. The PROMS data, I would say, you've got to prove the applicability of patient-reported outcome measures to be embedded in the system.
Yeah.
And they're not embedded because, who's looking at them? What are they being used for?
Yeah.
Is a primary care physician or another physician looking at the quality of life data over time? I would argue that maybe they should be. I'm not a clinician. Because changes in those quality of life measures are very predictive of outcomes, but they're not part of the clinical intake for data. So I think you're right. I think we're headed that way. And it's not a fast process, is what I would say.
Yeah,
I
great to
totally
have the
agree.
discussion started though, right? I
Totally
like having
agree.
those discussions. Yeah.
Yeah,
Thanks,
totally
Laurie.
There's one question there in the chat, Laurie. Do you see that one?
Yeah, so does the research question come from the research purpose, or the research purpose come from the research question? Which can we document first? Well, I mean, what I would say is the research idea comes from the area. For me, it could be bariatric care or infant nutrition or other areas that I'm working in now, fertility and exercise. The research question to a certain extent is, it's that pure definition that you will primarily use to help guide your research. You may have an overarching broader, like the study aim is, for example, for me to look at outcomes post-bariatric surgery. That led in itself to probably 15 specific questions. And each one of those also had a sort of a small aim and then a research question. Because that research question has to be so detailed. So your purpose can very easily come ahead of the research question. What's the purpose of the research? I'm actually interested in studying clinical, humanistic, and economic outcomes after bariatric surgery. What does that mean? Well, these are my specific, questions underneath that. But the purpose was actually to look at all those outcomes, of which there were really very limited data. So I think the question itself is the final piece. There's nothing beyond the question, apart from when you define the question to yourself, which really gets into inclusion exclusion criteria. And say, for example, an outcome which might be, mortality is an easy one, healthcare use, how will you define it? Is it hospital admissions? Is it visits to a primary care physician? So, there's so much time has to be put into that question. But once the question is defined and you've got that detail, and you literally can have it on a sheet of paper, and I used to do that. I don't do it as much anymore. I go back to it and I say, oh yeah, that's what we're answering. And when I sit around with the team or students, I go, this is what we're doing. Forget that. This is actually what we're doing. So the question again, just has to be specific, and it takes time. Very infrequently will you come up with a research question quickly. That's what I would, and as Peter potentially said with residents, time itself is a resource. So if we can help people come up with questions, if units could potentially have a list of questions, if we had some of that research up front, when residents or students came in and said, these are things we don't know, we've already jumped ahead and we could accelerate the research process. So there's, that's another side, of course, but again, that piece up front around the lit review and knowing the gaps is really critical.
Yeah, can I just join in that I think the distinction between clinical and research is totally arbitrary. It is one and the same. We deliver intervention and we innovate. This should be part of everything we do. And I agree that providing questions to learners is appropriate. You like to think a learner has their own initiative to create their own question, but it may be useful to give them their question also.
in the learning environment. I think it's like when a master's student comes to a supervisor, you tend to have a question ready for them, or at least, the idea of a question. If a doctoral student comes to me, I say, tell me what you want to do. So I think it just depends. There's definitely some different characteristics depending on the type of learner, I would say, as well. Yeah. Yeah, somebody's just asking about references. I mean, certainly the clinical epidemiology textbooks typically have some good references. I mean, the text that many of us use, I'll just show you here kind of online. I mean, many people may or may not be familiar with the clinical epidemiology textbook. I mean, I could probably provide this resource to Julia, but there'll be others, but this has a specific chapter on research questions, and many texts that I do have. And another book that I like to use actually is a book on how to read a paper by Tricia Greenlaw, which is actually about dissecting and reading research papers, but it also gives you, she's a fantastic family physician in the United Kingdom, but very academic. And this is a series in the BMJ as well, but there's chapters on the research. There are chapters written and papers written on the research question. And again, they're not that different from some of the criteria we talked about. And, the PICO question, but, sometimes it takes a bit of time to just kind of take all that in and understand what it is you're trying to achieve with the research question. So those are just a couple of resources that I tend to use.
And if you are interested in getting more information, or you want to kind of get the names of those resources that Laurie shared, feel free to send me an email. I'll put my email in the chat there. We can connect you with those.
I can give you those specific ones too, Julia.
Perfect. So I know we're just 5 minutes over time. We'll give maybe a minute or so for people to think of any kind of last minute questions. I will just add that, as I said, this was the second session in our research design series. So we do have a couple of other quantitative research design series webinars coming up. Next week, there's going to be a session on clinical trials. And the following week, there's going to be a session on non-traditional experimental study designs. So those are going to be quite exciting, I think, to listen to. Moving into March, we're going to get into our qualitative design session. So we'll have an intro to qualitative design from Holly, who's here on the line. And then we're going to have a session on interpretive description, and then a couple more after that. So all of our session links for registering will be up on the website, or are already up. I'll put the link again in the chat, so you can go there and register for those upcoming sessions. And that's where you'll be able to see all the recordings as well for previous sessions. We do have a letter of completion program. So if you attend 6 sessions within a 2-year period, you do receive a letter of completion from NL support. So just make sure you register for those, register for the sessions, and then send me an email if you'd like to be part of that. If that's all, if anyone has any last minute questions or comments, again, feel free to reach out to me if you have any kind of last minute thoughts, or and I can connect you with Dr. Twells, or we can kind of see how to go from there. But otherwise, thank you, Dr. Twells, for participating and joining us for today's webinar. I think it was a super interesting topic. You covered a lot, and I think it was also a nice way to flow from Holly's session last week on the intro to quantitative design. So I learned a lot.
Perfect, thank you. Thanks everybody for coming, and have a great day.
Thanks everyone, take care.
Thanks, bye-bye.